Welcome back, Health Impact audience. We've already had some really good discussions about health equity in general, access in general, but we really wanted to dive a little bit deeper into the realities of what's going on the ground, and how do we actually do something actionable to help with all of these equity, access, and other problems that we've seen have surfaced, especially over the last year. We've known about them for many, many years, but it has definitely surfaced bigger and brighter, as it were. The light is being shown on them now. But the equity problem is in two areas. One is, do we know that people are getting equitable access? And one subject area, we're going to cover that today. But maybe a good place to start is, even if we statistically can show that everything is equitable, do people trust our statistics? Do people trust us when we tell them it is equitable? And in fact, this is what we've seen over the last 10 or 20 years is things could be factually correct, but culturally unacceptable, right? And so when you see something culturally unacceptable, sometimes it's about trust. So that's really where I'm going to start with our panelists today. And we've got a power pack group. So Ashma, I'll let you do a quick introduction, and then Ray, and then Ram. And then I'll start with a quick question for Ram to set us up on the topic. So Ashma, welcome.
Well, thank you. First of all, honored to be here. Such an important topic and something near and dear to my heart. This is Ashma Gupta. I lead global healthcare solutions for Google Cloud. In this role, we work with industry at large, meet health systems, payers, and stakeholders across the globe to see how they can really reimagine healthcare, not only during COVID, but also what does the new normal look like. And what we are seeing and how this connects to this panel is, as the lessons of COVID-19 are learned, how do you reimagine healthcare that takes this healthcare disparities, social determinants of health, and build for the future? So happy to be here.
Excellent. Welcome, Ray.
Oh, well, good morning. Well, thank you for including us Health Impact. This is a really important topic. I'm so happy we're having this panel here. So I'm Ray Lowe. I'm the Senior Vice President and Chief Information Officer for Ultimate Health Services in Los Angeles, California. We are one of the largest community health center networks in the country. We serve over 300,000 patients and 1 million visits a year. Many of those are mostly Latino, multi-ethnic, and many of them are 200% below the poverty level. So this conversation today is really focused in terms of health equity, and the vaccine and the distribution of the vaccine has really identified some cracks in our health systems and what we need to close those gaps. At Ultimed, we are the last mile provider in the community, of some of the more impoverished and low income areas where the essentials workers live. And I hope that you find that our comments are interesting and you can learn through it, and we can all improve the overall well-being and remove this health barrier.
No, and welcome, Ray, because of what I loved about what you guys are doing is you're not reading about this somewhere, like you're practicing it and seeing it every day. So definitely welcome. And Ram, quick intro.
Oh, thank you, Shahid. And it's a really honor to share the panel with my co-panelists. We've all the exciting things they're doing, and it's happy to be back again. I've been in the panel a couple of times, and it's been one of the most powerful programs you guys put up every year. So my name is Dr. Ram Raju, and I had the honor of heading the 2 largest public systems in the country in the last 20 years. I was the president CEO of Cook County Health System, the 3rd largest public system in the country. Then I was at New York City Health and Hospitals, the largest public system in the country. And I've been working on the health equity and social determinants of health for the last 20 years. And in that journey, I've been a national spokesperson, and I chaired and also in the board of many health equity organizations across the country. So it's really a pleasure to be here today and to share my ideas and thoughts with, and also learn from my co-panelists. Thank you for inviting me.
No, the pleasure is definitely ours, Ram. And I wanted to start with you because you've spent so much time at these, especially on the government side. And even now, even though you're not working directly inside government, you're working with them on a regular basis, whether it's governors, mayors, et cetera. What I wanted to get your sense on was, given the last year and how much work you've done on health literacy, I mean, that's one area you've taught us a lot about. If you don't get the literacy right, whatever else you try to do, you're not going to get done, right? Because, and you've given a really good example in the past about, hey, if everything is in English and designed for college graduates, what kind of conversation are you going to have with people who are not college graduates and don't speak English? And that is an equity problem, right? So start with that. Tell us a little bit more about what have you done in the areas of health literacy and how does that improve? And then how do you find out who are the most vulnerable people so that we get our right data in place so we can do something about it?
Great, thank you, Shahid. In healthcare delivery systems, we confused patient education with health literacy for many, many years. We believe that we gave a patient education. That simply means I gave you a list of things to do or a piece of paper, and we expect that I've educated you. And we have patient educators in the health system, and they basically, that's what they do, right? And we have not done a good job of it many years. The only thing we have done in the 50 years is now we translate them into 5 different languages. That is the best we could do so far, right? So education is different from health literacy. And so one of the things we tried to do that was, we don't want to make the same mistake some of the education system in this country makes, that we believe that everybody learns at the same pace and everybody has got the same level of literacy and everybody learns at the same language level. So one of the things which was very obvious to us as we are doing this, we started before the COVID, but it came very helpful in COVID, that we created a health literacy platform. The message will be the same, right? But the technology and the AI will actually help the receiver of the message. It can actually bring it to the literacy level they want, and they can translate them into the language they want. And most importantly, they can also choose the medium in which they want to receive, because some of us are visual learners. Some of us are really audible learners. Some of them just read a paper and then we figure this out. So you can get the same message. It is not at the receiving end, you have an opportunity to change the message, how you want to receive that. And this found to be very, very helpful during the COVID. We usually use that for colonoscopy schedule, and we showed that people who really get that tend to keep the colonoscopy rates much higher. The failure rate is much lower, people don't show up, and that's better, right? And they're unprepared. But the COVID came in, we started using that. And it was very obvious to us because when our leaders, in all good intentions, start talking about to the people how to do these things, unfortunately, most of them needed either a college level education to understand them, or to be the English, to be the first language to understand what it is. So we felt that it didn't really reach the people we need to reach. So we used this health literacy platform, and we've had enormously good results in New York City. We're able to really make the people who need to listen to the messages much better do that. So that is something which we need to really incorporate into our systems. After the COVID is over, we need to really use it as a part of our system to educate and to improve the health literacy level, because healthy behaviors is the reason for 40% outcomes depends on healthy behaviors. Other 40% depends on socioeconomic conditions. And the only 20% depends on all the clinical things we do, all the greatest achievements we have made in this last 5 decades, all the great things we have done, all only for 20%. For example, if the patient has got diabetes, the social determinants of diabetes is the food insecurity. If they live in an area where there is a food insecurity, that means there is no grocery store 5-mile radius and they don't have a car, they will never be able to adhere to the diabetic diet. So as a physician, the only option I have is to give you more medication. So for so many years, we compensated the social issues with more medication. That created a multi-pharmacy problem in the United States, right? So once we did that, we also figured out the social determinants is a major factor, of the outcomes of the people, because we always wondered for the last 20 years, why we as a doctor give the same treatment to everybody. Why somebody else gets a better outcome than the other person. Initially, we always say it's all because of genetics. All genetic, that's a part of it. Yes, genetic is a small portion. It's only 5%. Most of the people are where they live and what they work and what happens to them makes a difference. An asthma patient, we can give the best medication, but if you send them back to the apartment which has got roach problem, cockroach, then he's going to come back. It doesn't matter whatever medication he gives. It depends on what his problem is. Really, you need to have an exterminator take care of the roach problem. That is what is going to happen there. So we created an index called Social Vulnerability Index in Northwell. That means it's called SVI. We have taken 15 mostly prevalent social determinants in that neighborhood. And we created an algorithm by an AI and said, we classified people according to where they are, 1 to 10, 10 being the highest social determinants. So when the patients come in, the doctor sees not only the clinical risk, also sees the social risk. And if there's a social problem, they refer the patient back to some of the community organization, not-for-profit, and all those things, right? And the homeless problem will be referred to homeless agencies. And we use that very effectively in Northwell, right? To take care of regular patients that they come in. We address not only the clinical issue, social issue, so the holistic treatment. That proved to be extremely helpful in COVID because we were able to absolutely predict and show that people with the high social risk had more chance of getting infected, more chance of getting admitted to ICU, more chance of dying of the disease compared to people with the less social issues. Yeah. But there is a lot of things saying that, the Black Latino population has got a problem. Yes, you're right, because they also have more social risk factors compared to the rest of the people. So it is not it's not the end cause. That is actually the end result of what happens with that. So this found it to be very, very helpful. And I think we has come to a level in this country, especially with our partners at Google and other people, that we have to incorporate social risk factors into the clinical risk scoring so that we can take care of the patient as a whole. And that is the only way we can get into social equity, because I believe you cannot have health equity without social equity.
Yeah, no, I love it.
There's no health equity without social equity.
That is a great point. No, perfect. And that's a perfect setup. Ray, you're on the ground every day dealing with thousands and thousands, if not millions of patient visits a year. Based on what Ram just really encapsulated well, which is this social vulnerability index, maybe pointing a way to who needs the most attention, health literacy pointing the way to who needs the most attention. Is that really a problem on the ground? Or do you know who needs the most attention and there's just some other problems because you can't deliver the attention that you need to provide?
Yeah, I do agree with it. I mean, the pandemic really started about a year ago, right, to the date, and when we really understood what was happening. I mean, today, it's March 10th. I think this is when we actually went into high gear at Ultimate and had to flex and react to it. In the vulnerable populations, the underserved and low incomes, they basically ceased getting any type of health care. Right? They would come to our clinics. They were afraid to come to clinics, afraid to go to hospitals, afraid to go to emergency rooms, which further exacerbates any type of chronic conditions they could have. And in the more vulnerable communities is how do you generate that trust that we know you, that we understand you, that we're going to give you timely appointments, that you're not waiting 6 hours in the ED, you're not waiting for a long time. How do we offer new ways of you to receive care? Many of these folks fall into the Medicaid or Medi-Cal population, and many of them don't speak English. As Ram has spoken, right? They speak, many of ours are Spanish speaking, and they can only have a 3rd grade education. Their housing situations is multi-generational and not a traditional nuclear family in a 1-bedroom apartment. They could potentially be living in a garage attached to a house around those. So they have these other challenges in terms of how that they live. And then as they're watching COVID unfold and who can get shots, right? And on the news, you'll see Disneyland, Dodger Stadium, these mega vaccination sites, and the ability to schedule the shot, it's complex. It takes a lot of time. You really have to be very persistent to work through and schedule it. And we've created, this barrier that our patients can't understand what to do. It's no fault of their own, right? It's just that the way that the feds of the states have put it together, it's just not one size fits all to Ram's perspective in terms of how information is created. And further, with us being one of the largest community health centers in the country, we are the community, right? We're constantly in the community working with food scarcity, working with voting rights, working with healthcare, working with AIDS outreach, et cetera. And so the role that we play, is really that last mile to deliver that care to the most vulnerable population, culturally, linguistically, and culturally sensitive, so that it addresses their needs. And I think that will go and help close this gap that we're talking about.
So Ray, in the cases where you have audience members that care about what you care about, what would you want from them? Is it, as Ram was saying, and of course you've got, from Google, Ashima sitting here saying, dude, I can preview any kind of information at any level of granularity with all the best AI in the world. Is that what helps you? Or what is it that you would ask for from the community members or others to help you get what you need to get done for equitable distribution of healthcare?
Yeah, so it's such a pertinent question right now. I mean, at Ultimed, we went from being very in person, with all of our patients. We never did a video visit, right? And we did over 80,000 telephonic televideo visits in the last year. And so when you look at the underserved population, this is a game changer, because before they'd have to take a bus, take off a day from work, have a threat from a potentially hostile employer because you're an essential worker, so on and so forth, you be replaced around there. But what's further we're observing is that there's a new social determinant of health that's emerging, and I really want to call it like a digital desert around there. And so like all of this great technology that's out there, I mean, I don't know that they all have iPhone 12s, 10s, et cetera. They may have iPhone 4s. They may have downstreams, and they're purposely not intending to be excluded, but the technology providers are skewing to the latest OS, and it's leaving them behind. And the other challenge, again, is when you're dealing with these essential workers and you're looking at the low income folks, if they have to pay a $50 cellular bill, or they have to spend $50 on food, it's a clear decision for them. They're going to buy food. I am encouraged. I read something in the New York Times just recently that there's supposed to be some new bill from the FCC that they're going to be providing internet services to these more impoverished areas, which I think has to happen. And this includes both urban and rural areas where these divides are developing, because we could put all the best technology out there, right? Mm-hmm. But if we can't deliver it culturally linguistic, sensitive, make it easier for them to use, and of course the connectivity or the endpoint device, we've failed that part of the population.
No, I love those points. And in fact, Ashima, I know you were dying to jump in because obviously you have solutions for almost every one of the things that both Ram and Ray talked about. But specifically, I know you guys have announced a recent $150 million or so program on the vaccination and literacy and all this other problems. So I'd love for you to kind of like recap what Ray and Ram were talking about from your perspective, and how you can actually walk into organizations and do something with them today to tie all of these connected points that you want to tie through. So jump in here, let's tell Ram and Ray what we can do to help out.
Well, first of all, thank you. And this is pretty inspiring to see the ecosystem effort to address health equity, which has been existent for a long, long time now. So stepping back, let me begin by sharing our North Star. I'm from Google Cloud, which is part of Google overall umbrella. And our mission is a pretty timeless mission from a Google perspective to help organize world's information and make it accessible and useful. And our mission in healthcare is a reflection of that. So with the organization I sit in from Google Cloud, we work with health systems across the globe to help them organize their data and make it accessible and useful. And as you can see, it's not a conventional mission. At its very core, Google embodies helpfulness. So today, 1 in 20 searches are health related when you come to Google. And as we all have seen, health information influences all of our lives and significant opportunities for improvement in personal wellness. And also, this mission came to light during COVID. It transcended to providing users information to keep them safe, informed, and connected, be it finding the COVID cases near my zip code. So we have worked directly with public health entities like the WHO and CDC to make official information accessible through a comprehensive search experience. And this was done globally. We worked with over 100+ government agencies across the globe. So when today you search for queries related for COVID-19, and now when the vaccines are coming out, we have announced a $150 million fund for the equitable distribution of vaccines and finding the vaccine-related information. And so that's one part of, from the Google perspective, our work that we are doing. But where I sit in, COVID-19 has shed the light on the broad disparities as my fellow panelists are sharing here. And here's an opportunity for us to, as an ecosystem, to come together, right? We all are seeing the patients are right at the center of it, and many social determinants of health, social, economic, physical environment where you live. We often talk about in healthcare, Shahid, for a long time that your zip code is the indicator of your health and well-being. And yet, what it means from where I sit in is we must take, as a community, as a proactive approach in building systems that can harness data to address disparities, both in how we approach scientific discovery, both in how we approach taking care of patients, be it telehealth, we talk about broadband access, and in many cases, this is where I believe technology companies like Google and technologies like Google Cloud can truly help and to be that backbone and will be pivotal. As we all also know, the healthcare data is pretty siloed. It has many different assets, data access, we talk about interoperability, but also we have a robust public data set program where we bring in the relevant public data sets, be it census, be it from your community, we had community mobility reports. These are now made available on the platform. And to make it possible to share data or analyze trends across a large population, right? So that's where we believe the opportunity here is healthcare systems have their own data, but there is data that exists, the public data sets, and we are doing the hard work in curating, making the data sets available to be combined for the novel use cases that we talked about, be it chronic condition management, like when we talk about the diabetes example, or be it equitable distribution of vaccine. We have also launched our solution in the vaccine management. And there's one other simple example, Shai, that I want to bring in, which is a language barrier. So our work in conversational AI, which is multilingual conversation agents, that help reduce the barrier. So imagine on your website, you have conversation agents that can speak multiple different languages and can be appealing. So that's kind of how I want to kind of wrap up from technology perspective. We are behind the scenes and here to serve the community from, COVID-19 is a pivotal moment for all of us to kind of come together.
Yeah, no, exactly. And so what's really cool is, so I'm a developer, I'm a software engineer, and a lot of hospitals and health systems, especially, thinking about Ray, Ram, you guys work with IT people all the time. You have a lot of folks that want to do the right thing at hospitals, but it seems to take them forever to get their vendors to often jump in and be able to fix the software and hardware, et cetera. So what's really cool about what Google often does is I can literally sign up and begin using all the services this morning. I can go in, hit this, and I've got APIs for AI, APIs for conversations, et cetera. So Ram and Ray, you want to talk a little bit about that capability of how do we change the hospital IT of the future to say, look, we're not just going to be a bunch of installers of a whole bunch of other software and hope and pray that they work. No, we're going to take the core systems, they are already there, but now we've got these capabilities, whether it's the Googles of the world with, almost instant APIs, what could we start doing pretty quickly to help with health equity? Because the core software systems like EHRs and RCM, et cetera, they're not going to help you with health equity at all. You're going to have to go to additional data sets. So Ram, any quick notes?
I completely agree. It's really music to my ears to see Google doing that, because the problem we had was we had healthcare data, not a healthcare really. We have a sick care system. We never had a healthcare system in the country. It's sick care system. So we have sickness data, then we have the public data, which is go to public health department. Then there is human services data, which is developed by the agencies keep the human services data. Then there's a wellness data, which is basically outside the healthcare system, because all the Fitbit, everything, the healthcare system doesn't do anything about it. It's all outside the thing. So if Google can bring them together and create an easier way of creating a risk factor, that's what I was talking about. If you bring all of them together for individual and then create a risk factor that you are at risk, right, of doing that, you're right. Zip code matters, right, as a part of it. The zip code matters because they have a high social vulnerability index. Their vulnerability is probably around 9 on the scale of 10. That would be, if you can bring them together, then it will be very easy for the hospital system saying, okay, fine, we're going to take the Google and we're going to install into that. So that when the patient comes in, high social risk, I'm going to take care of his diabetes. I'm going to refer the social workers. They're going to follow up on the other issues. What you said is music to my ears, and I think that will really be a game changer for the people. So that we in healthcare delivery system need to understand that what we do only accounts for 20%. The other 80% is outside our system, and that will be helpful to us.
No, I love it.
Thank
In fact, the way to think about that, Ray, on your side is then one thing we've not had in the past was you can't just build a bunch of clinics in all underserved areas and hope that that's going to work. But you can give away iPads, you can give away Google tablets, you can give away Android phones at the low end, and then bring healthcare to them through these devices. Is that happy talk, or do you think that you could actually pull that off if you pull the community together to say, let's take healthcare to the people instead of making them come to us?
Yeah, I mean, I think that's where we're moving towards. What you're proposing is really a really good state. We're looking at how do we do that. But really what it's about the consumerism of medicine, and it's having the hospitals change their view from being hospital centric to being patient centric, right? To delivering the medicine to the patient. I mean, I think over 90%, 95% of all medicine is delivered outside of a hospital, right? So that digital front door that enables them with the symptom checkers, with the AI behind them so they can understand it, that ability to do a triage with a patient, and then if the patient needs to go to an ED or needs to go to a clinic, we should be able to use the AI analytics, schedule a ride for them so transportation comes, so there's no gap in care, which creates, it removes a barrier for an adverse outcome, right? We're talking about consistent population healthcare management. And it's well known in IT that there are a number of blocks and issues with interoperability between hospitals, health systems, community agencies, so on and so forth. So I think, our folks at Google can help us solve those problems. But I really think what we're looking at is how do we have the appropriate technology for our patients? And more importantly, they need to know how to use it. It can't be scary to them, right? It needs to be easy to understand. And again, when I talk to them being culturally sensitive, different cultures look at the devices different ways. And there is machine translation, and then there is different vernaculars. Like you could speak Spanish in multiple different countries in Latin America, and different words mean different things. So, we have more to do in this space. That's what we're about. That's what we're going to in terms of our delivering quality care with that exception. I'm encouraged by what I'm seeing happening out there, but we got to make sure that this digital desert does not preclude the most vulnerable, does not create a wedge. We have to make sure that as the vaccinations happen, we do not have a two-tier society of those that are vaccinated and those that are not. That's honestly kind of my biggest fear of what's going to come out and how it will end up normalizing over the next time period.
Oh, I love it. And in fact, we got about 30 seconds left before we have to head to our Q&A. So Ashma, I'd just love for you to kind of wrap up with one very specific area, because AI has come up a few times in this discussion. AI itself can also be unequitable, right? Can learn to be unequitable, and we've seen this before. What are you guys doing from a Google perspective on the AI bias problem? And maybe that's a good way to then open it up for questions. And we're going to get lots of other questions coming in over the next few minutes. So maybe just talk about that, and we'll jump into Q&A.
Thank you, Shahid. So I think one thing I would say, I think being proactive about leveraging those social determinants data sets in how we build the systems and digital infrastructure of the future would be critical. And now jumping on to our AI principles. So Google is committed to a core set of AI principles. We have 7 of them. And these principles lay out how we think about using technology to solve important problems. But they also identify important challenges in that we need to address clearly, thoughtfully, and emphatically, and responsibly develop technology. So there's more. I will share the link shortly with the team in terms of what are those AI principles. And the fairness, equity is a key part of those principles. And in closing, there's not one company that can do it alone, so I'm not going to sit here and say Google will solve everything. We are committed to bringing the helpful tools, helpful technologies, and bringing it to share with the community, and at the end it will take this collaboration, public-private partnership, to make it bring to life.
That's perfect. Perfect way to get to the Q&A. So Ashima, thank you very much. Ray, thank you. Ram, thank you. And we'll open it up to our audience for questions now. All right, so we're going to kick off. I think there was a good question that was posed in the chat here, and Ashima, you did answer it in there, but if there's anything you'd like to add, the question would be around what are some innovative, interesting, unique things that you've seen hospitals and health systems do with the data that you guys are creating, Ashima? And then I'd love to see Ray and Ram provide any examples that they might have of maybe data sets that they would like to see to help improve equity as well. Ashima, you want to go first? Ashima, are you able to hear us? Looks like maybe Ashima doesn't hear us. Okay, so let me pose the question, Ray, over to you. Is what are the data sets that you think firms like Google could be putting together so that you guys can get the additional data that you need to help with the health equities?
Sure. So thank you. So you know, when I'm talking. Sorry, it's all about interoperability to me, right? And I look at the information blocking requirements of what's happening between Commonwealth, care quality, what's happening with other systems that may not be on an Epic or Cerner platform, and then how do we aggregate that longitudinal data so that as we're doing population care management or as we're doing interventions, so that it reduces readmission, ADT information, discharge summaries are sent automatically to primary care offices. Primary care offices records are available to the hospitalist or providing care, inside of the hospital, et cetera. So there needs to be really that much more freer flow of the data, between the multiple entities. And obviously, you have to take it back to the payer side as well, because what they are approving, for claims and authorizations, right, does affect the care. And I think from the AI perspective, right, perhaps there could be a way that alternative therapies or approaches could be used that could perhaps fit into a managed care model, right, as we continue moving to this value-based care system.
Sure. And Ray, just to extend that a little bit more, are you thinking that at this point you're still having fundamental technical challenges with infrastructure to do what you're trying to do? Or are you actually finding that the infrastructure is there, but you're not getting the healthcare partners in your area to work with you in doing the sending of the data?
Yeah, it's I would say that they're still there, right? For a lot of the big systems that are fully integrated, that they've figured it out. In the mid-size, we're a mid-size healthcare provider. It's harder. We don't have these large teams. So when we're looking at, again, I kind of look at Google just because they have such vast resources, and we use Google Cloud and other services from Google that are absolutely awesome, right? But more like kind of an open source or something that we can all benefit together from versus actually having to pay for it.
Yeah.
We talked about aggregation of services, integrating it, but oftentimes what happens is companies or service providers are going to start adding margin on top of margin on top of margin. And then the value of the bundle it's dispersed, or you can't afford to do it. So I think we really need to move into this free info sharing area, so the health information is not restricted. Shima, I'm hearing great things about Google Health and what's going out there, and some of the most innovative health systems are really adopting it. I'm going to take that to my portfolio in terms of how we start playing more of this into it, because it's more consumer centric, right? And then it ultimately goes the term, the digital twin that you have out there for your medical. How's that being treated, right? Before we actually treat the person.
Right. And I think just to add to that, we, from the Google Cloud perspective, we are providing the same data sets. It's pretty hard work in storing, creating the data set, curating it, and making it available on the platform. And as with all the data in the Google Cloud public data set program, we pay for the storage of the data sets in the program. You can also do free queries, and I think there's a limit up to 1 terabyte free each month. The point being, we want to encourage the usage and curation of the public health data sets, and then paying for the storage. And coming from a health system myself, getting this public data sets onto your own environment is not an easy task by any means. So I would say my message to the audience would be to not reinvent the wheel, see where help is available, and lean on to see what data sets are there. And if there's recommendation for more, we'll continuously enhance our public data set program. And also the compute to a certain limit is also free. So definitely lean on and help us make this program more relevant, more better by sending us suggestions and what other data sets are needed.
Yeah, and one other thing that Ray just mentioned, and I'll bring in Ram for another health equity question in a minute. But on this side of so when HIEs were created back in the strategy for health information exchanges were created back in 2004, the idea that you'd have a national, which would have sub networks going all the way down. This was all pre-cloud, pre-SaaS, pre-like everything. The idea of HIEs, which is what basically Ray is very nicely saying he's suffering from, is there is no true HIE that can get everything over to him that he needs it. Is GCP a model for the next proper HIE? And what do you think, Ashima, from the GCP perspective, Google Cloud perspective, for healthcare information exchanges, and how you might either augment or enhance what's already there today?
So there are two parts to the question. One is the heart of it is at the data. We all have seen data plays a critical role. And once we have the data available, curated, in access to those data sets available to the healthcare ecosystem at large, and we are not just making the storage and data set available, we're giving you the tools, and we believe this will be a kind of boon for researchers. So in that regard, access to data through the public health program is available. Then you're talking about the second part, which is the health exchange. And in that, to me, we have tools like, and we all are big fans of interoperability. Exchange means, and having implemented NHI in a smaller fashion at Kaiser, it was like long PDF documents, CCD 32. It's pretty hard. And what these APIs that we see now with the FHIR interoperability, that exchange, common semantic interoperability is going to be key. Mm-hmm. And there, of course, we have tools like Cloud Healthcare API. But Shahid, to your point, is a mindset shift. Right? A, lean on to the data set that are available. B, leverage modern techniques, JSON-based FHIR access. That's what internet runs on, like the APIs, and not sending these big appliances. And I think modernization of the HI infrastructure is the key message here.
Yeah, that's a great point. Ray, did you want to add something? Because I was going to ask Ram about health equities around caregivers, which is a good topic that came up today. But did you want to add something there?
I agree. I mean, I agree with everything Ashima is saying. I mean, it's a challenge you all face, right? Fortunately, in April, there's some new information blocking that's being relaxed, as well as in May. I think the proof in the pudding will be how well that hospital and ambulatory acute flow of data will work. I mean, I don't know if those dates will be met. I hope they are, but I think it's going to take longer for that, especially as it trickles down from your large systems to your community hospitals, your community providers.
Yeah, and that's why I think maybe it's Ray. If you can, think of it as even though you're a midsize, you still you wield some power. I think going to your local HIEs, et cetera, to say, well, what would happen if you thought about the next generation HIE being rooted in modern cloud principles, meaning a cloud first HIE, and what does that look like? The data blocking rules are going to enable these kinds of things, et cetera. But the thinking has to come, unfortunately, from buyers like you to say, look, I'm not buying anything that is still looking like it was designed in 2005. What I'm buying is what's the stuff that was designed in 2019, 2020, 2021, et cetera. And just like the JSON fire, et cetera, I think at some point we have to kind of put the pressure on the old legacy guys to say, either you change or you are gone, right? We're just not going to use you anymore. And the only way that could happen is if buyers make that assertion, and then the suppliers know that you guys are being real.
Yeah, I think kind of like my last one on that is it's a partner versus the vendor, right? I mean, again, we're fortunate that we do have an Epic inside of our environment, and they're really able to help us. Even when I was looking at my turn, how about scheduling associate working, we're really following kind of their roadmap because they have the power. I mean, Chili Foster's got a lot of power to make things happen for us, right? And so they do advocate and help us fight those journeys, and it's a very strong voice. So I think if there are partners and vendors out there, is listen and please be a partner. Don't be a vendor, right? Help us advance this together so that we improve the overall quality, and the right outcomes will happen no matter what.
Great. And so, Ron, we'll let you close out here over the next couple of minutes. So there was a question, especially earlier this morning, about health equities and how they might apply to make things either worse or better if you had the right caregivers around you. So what do you guys see with respect to how health equities improve or get worse given caregivers in or around the network of patients?
Sure. I think that's a very good question. Just want to touch up on one point.
Yep.
The fact of the matter, both my co-panelists made it eloquently clear that we have to ask for information. We don't need data, we need information. So a lot of times what happens is we don't know what we need. And basically, they sell something and we adjust our system to fit into that. In other words, we don't buy the shoe which fits our foot. We already bought the shoe, and we always cut our foot to fit into the shoe. And that's the way healthcare always worked for many years.
I love Ram's examples.
So the question would be, at the end of the day, is if you're doing social determinant data, you got to know what social determinants are affecting your patient, because that could be very different geography by geography. If somebody makes a social determinant index calculator, like Google one makes one, it cannot be all 4,000 social determinants all put into one of them, because some of them matter, some of them don't matter. So I think there must be a better collaboration before the product is made between Google and the IT and the medical healthcare people, so that we can create something together, as opposed to they already created something and then they basically come and demonstrate the product to you, and if you like it, you buy it, or you just make adjustments to do that. So going back to a caregiver, this has really gone through this evolution, because when we first start the health equity is because of color of the skin or ethnicity. We basically felt that a large portion is because of lack of cultural competency among the caregivers. So we came with this great idea, right, in 2007 and 8, saying that we are going to teach everybody cultural competence in healthcare. So that became a joint commission mandate. So we trained every health caregiver in the United States. They all have to take cultural competency course. It looks stupid if you really look at it, because you can't make somebody culturally competent by listening to 14 slides and 20 minutes presentation. Suddenly I anoint everybody, you're all culturally competent, please go and do whatever you need to do, because you're all good now, you know how to take care of it. So since it did not work, because we know it will not work, because it's just adding another joint commission mandate to the existing problem, we thought inclusion and diversity. So we started inventing that we got to get every organization had got the diversity officers, inclusion officers, we bring everybody into that, and all those things came in there. It really did not make a big difference to the social determinants problem at the end of the day, because even if you have the culturally competent, diversified healthcare leader, you don't have the data to understand the social issues of a patient to be able to provide the best care possible. So the problem is you are trying to get the seed, which is the healthcare leaders or the caregivers, more powerful, but you don't give them the soil in which they work. You have no knowledge about it. So inclusion and diversity in the workforce is a great idea. It actually opened the doors for a lot of minorities to people in the country, which they would otherwise would not have gotten, right? I am one of the beneficiary of that, I can tell you myself. But that is not going to solve the social determinant problem, because it is not the seed, it is a soil.
Right.
It is basically, even if you put the best healthcare worker, the most diversified healthcare group caregivers, and the best culturally competent group into the mixture of people who live in, enormous public safety, transportation issue, food insecurity, that is not going to get better. So I think we have been looking for the magic bullet for many years. So it came from, cultural ethnicity to cultural competency to, to inclusion, diversity, to social determinants of health. So we are basically looking for one magic bullet. Of course, somebody will come in and they say, this is the way to do that. And hopefully Google will give us this, product, which you can flip into that, and suddenly we can improve outcomes for everybody. Okay,
Well,
that
there
is
is no
really
product.
not a very.
I just,
I'm just putting it in that one. But
no,
that is
actually,
not.
there's no
Google can
product
make
like
the
that.
product. No, again, Google can make the best product, but it is not the product. It is the
Right.
people how they use it, the people who use it, and whom you use it on. So there are two important things. So I think diversity of the clinical workforce is a great thing. It's a wonderful thing. It's a great job program. It's a good thing. Economy gets better for everybody. I'm completely support that. But that is not the solution for the healthcare equity in this country, because healthcare equity is not the problem. The problem is social inequity. If you cannot fix the social inequity, you're not going to fix healthcare equity. So that I've been very clear on that. If you want to create a social inequity, you want to create social equity in this country, you need to have an economic opportunity. You got to have a level playing field. You need to have a social justice so that you're able to create that. Create economic opportunity, social equity will come. If social equity comes, health equity will come with it.
Yeah.
So we are approaching it the wrong way.
Yeah,
Yeah,
no, that sounds
you
great.
know-
And unfortunately, we're out of time, Ray. But if you
Okay.
have some time to join us later at the end of the day, we're going to have like an
Sure.
entire hour. We can have a free-form conversation. But I do apologize. We got to cut off here so we can get to our next session. But the lesson to take away from Ram is buy shoes that fit. Do not cut off your foot to put on small shoes. See you guys. Thanks all. Thanks, Ray. Thanks, Ram. Thanks, Ashima.